Hi, everyone. Good evening. I know everyone's still taking their seats, but as is usual for the World Health Assembly, we're running a little bit late, so I think in the interest of time, we'll get started. And some of our other honorable guests will trickle in as we carry on. So first, I just want to start by welcoming everyone here tonight so far in the room and those online. Thank you to all of you for joining us as well. To this event co-hosted by Rare Diseases International, the WHA Foundation for Rare Diseases, the Hong Kong Rare Disease Collaborative Network, and the International Federation of Pharmaceutical Manufacturers and Associations. I remember 1 year ago we were here in Geneva celebrating the imminent adoption of the World Health Assembly on rare diseases, just days after. And it's incredible to see, how far we've come since then, and still how much work there is to do. But that was really what, cemented rare diseases as a global health priority at the highest level. So I think, we need to take a moment to reflect on that. Tonight, we have a great group of speakers to hear from, and we'll be exploring sort of a different side of rare diseases, or a different side of this resolution. And that will involve exploring how building health and social systems that meet the needs for people with rare diseases, in turn, build systems that can meet the needs of everyone. And I think this is a really important topic, especially, as the global health architecture is changing, and, as resources are tight. I think this topic is really top of mind. So I'm really looking forward to hearing from our speakers. I want to give a special thank you to our ministerial representatives who are joining tonight, as well as all of our other speakers and attendees. To begin our session tonight, we've prepared a short video, and we want to play this first to introduce you to our incredible rare disease community around the world, and also show you sort of why this resolution is important and why it means so much to the rare disease community, and what the potential impacts are. So I would now, we'll just turn your eyes to the screen and we'll play a short video.
Condition known as osteogenesis imperfecta.
I was diagnosed with retinitis pigmentosa 60 years ago, which is a rare retinal disease.
I have Usher syndrome type 1F. I have 2 children who live with Fragile X syndrome.
My son Hashim is 13 and uses wheelchair because he was diagnosed with a rare disease called SMA.
My child has WHA syndrome, and I have 2 kids with different rare conditions. One is a gene mutation, the other one is a chromosomal anomaly.
My son Mateo was diagnosed with a congenital malformation at SJD Barcelona Children's Hospital.
The biggest challenge for people living with a rare disease in the UK face is accessing the support that they need more easily.
The biggest challenge for persons living with rare diseases in Malaysia is that we are severely underdiagnosed.
The biggest challenge for people living with a rare disease in Egypt, the early diagnosis, lack of awareness, the treatment is very expensive.
The biggest challenge that we people living with rare diseases face in the US is that there's no cure for many of the rare diseases. There's very little research and development cure for many of the rare diseases because there's very little to no funding, including from the government and pharmaceutical companies.
Without a diagnosis, you're ping-ponged around the system, searching for what might be going on with you or your child.
Det är våran vardag.
Ja, det är berg- och dalbana upp och ner
Ja.
hela tiden egentligen.
I support the WHA resolution on rare diseases because it will acknowledge the challenges my son faces on the daily basis. And hopefully it will address these specific and very unique challenges. It is also about human rights, dignity, and equal opportunities.
I support the World Health Assembly resolution for rare disease because it will reinforce the development of guidelines and recommendations by the World Health Organization addressed to the member countries. Rare disease will have a flag in every geography.
I support the WHA resolution on rare diseases because as a mother of a son with a rare disease, I understand firsthand the challenges and isolation that we as families face. This resolution advocates for us.
I support the WHA resolution on rare diseases because it recognizes our needs.
Achondroplasia doesn't define someone, but access to care can define their future. Let's make it fair, and that's why we support Resolution for Rare.
I support the WHA resolution on rare diseases.
We support the WHA resolution on rare diseases.
We are few.
We are many.
We are diverse.
We are united.
We are rare.
We are everywhere.
Okay, so now to officially open our event, I'm pleased to invite Dr. Kristen Johnson, the chair of RDI's council, to provide some remarks.
Thank you, Alana. I'd like to welcome everyone here tonight and those online. Firstly, people who are living with rare conditions who are representing the voice of lived experience and patient communities from around the world. We welcome the parents, the partners, and the family members and friends and carers of those living with rare conditions. We welcome the health professionals who care and treat. We recognize the social care teams and welcome you for your facilitation of daily life, understanding that rare diseases are 24/7 and can impact every part of a person's life. We welcome the government officials who legislate and determine budgets for health and social care. We welcome the non-governmental organizations who build civil society through foundations, social enterprise, and charitable activities. We welcome researchers who devote their careers to rare diseases. And we welcome the biotechs, pharmaceutical industry, and healthcare sector who bring private funding to develop medical devices, medicines, and new therapies. And we welcome many, many more. Rare diseases are complex, and the ecosystem which supports them is equally complex. The World Health Assembly Resolution for Rare, which we celebrate tonight, and for which we are planning next steps towards a global action plan for rare diseases, only exists because of multi-stakeholder engagement and the support it takes all of us working together, collaborating to effect change. In the particular political context of the World Health Assembly, where a resolution can only be proposed by member states, we recognize the tremendous work of the two lead sponsors of the resolution for rare that they put into for making this resolution a reality. We thank the ministers of Egypt and Spain for their tireless efforts in galvanizing support from colleagues around the world, culminating in this resolution passing unanimously on May 24, 2025, with 39 other co-sponsor countries in support. The overwhelming success shows the understanding ministries have of the relevance and the importance of recognizing and supporting rare disease initiatives through policy at the global and national levels, an understanding of the impact rare diseases have on individuals and family life, and the knock-on effect on society and economies. The resolution sets all of this out clearly. However, what we are here tonight to discuss is the interrelationship of rare diseases within transversal policies and how rare diseases can be a catalyst for global health transformation. I highlight a few examples from topics included in this 79th World Health Assembly. First, universal health coverage. Universal health coverage must fully include all those living with a rare condition who currently face delayed diagnosis, high out-of-pocket costs, and limited access to essential medicines and services, leaving them behind in UHC efforts. By addressing the gaps for rare diseases, we improve UHC systems for everyone. Primary health care. Primary care is often the first point of contact with the health system, yet many people face fragmented or absent care pathways, delayed diagnosis, and limited referral systems, worsening their health outcomes and impacting their quality of life. Strong, people-centered primary care can facilitate early recognition, care coordination, and continuity across the life course. By addressing the gaps for rare diseases, we improve primary health care for all. Mental health. Data shows that people living with rare diseases and their carers experiencing significantly higher rates of anxiety, depression, social isolation, and sadly, suicide, driven by diagnostic delays, uncertainty, stigma, and limited treatment options. Mental health services are often not adapted to their complex, lifelong needs. Integrating rare diseases into national mental health strategies and promoting psychosocial care would help save lives and improve the quality of life for those living with rare conditions and their families. By addressing the gaps for rare diseases, we improve mental health provision for everyone. Health in the 2030 Agenda for Sustainable Development. Achieving Agenda 2030 requires addressing the multidimensional challenge of those living with rare conditions, who accumulate multiple layers of vulnerability. The health aspects of rare conditions can be complex. Living with rare diseases puts people and their families at risk of impoverishment. Their access to quality education is hampered. This then negatively impacts finding decent work. Women are disproportionately impacted, either as patients or as primary caregivers. We need multi-stakeholder partnerships for equitable health systems and sustainable development. By addressing these gaps in Agenda 2030 for rare diseases, we impact sustainable development goals for all. And lastly, but not least, maternal, infant, and young child nutrition. Many rare conditions depend on timely nutritional interventions, including specialized diets and supplements, to prevent severe disability or death. Yet access to these often simple, life-saving interventions remains uneven, especially in low and middle-income countries. Integrating rare diseases into nutrition programs, coupled with identification and early diagnosis through newborn screening, can allow early intervention, save lives, and greatly improve outcomes. Ensuring that nutrition policies address the needs of children living with rare diseases improves not only their lives, but improves nutrition efforts for all. Therefore, Rare Diseases International works towards a world of equity, where those living with rare conditions have their human rights respected through access to diagnosis, care, and treatment, and social justice. We recognize the opportunities rare conditions offer for developing innovative systems of multidisciplinary, person-centered care, for developing innovative financing models, for developing new therapies and treatments, and that in all of these areas, the benefits of those living with rare conditions would benefit all. Rare diseases can indeed be a catalyst for global health transformation. Thank you.
Thank you so much, Kirsten, for doing such a great job of opening the event and really setting the context for some of the great discussions we'll hear from tonight. Now I have the honor of inviting to the stage Dr. Rudiger Kresch, who is the Director of Environment, Climate Change and Migration at Interim in the new division of Health Promotion, Disease Prevention and Care within the WHO, and also a longtime champion of rare diseases.
A very good evening, and congratulations. Congratulations to a milestone that you have achieved in advocating for, in supporting member states, in negotiating as member states for this resolution that we're celebrating tonight, which was adopted last year. This is a milestone indeed. What a way, what a journey we've made in looking at people with rare diseases not as an annex to something because they're rare, but to see that rare disease is central to universal health coverage. Well, universal health coverage means that everyone, everywhere, receives the health care he, she needs whenever they need it, without falling into or facing financial hardship. And if we're talking about everyone, we cannot leave out 300 million people who are suffering from rare diseases. And now people say, well, listen, in universal health coverage, we're not even covering basic NCDs, not cancer care in all countries. We really have other problems. When I'm talking to my fellow colleagues, sometimes, of course, we need to take tough decisions. And would it not mean to first care for the majority of people who suffer from NCDs? And I say, yes, of course. But how do we do that? We would do that through tobacco control, alcohol control, better nutrition, better activity, physical activity, meaning transport systems and so on, and air pollution. And then we would not need to care for those people in hospitals. That would free up a lot of resources, as over 65% of the 75% of people with NCDs could be prevented. And then, all of a sudden, our minds shift, because then we say, well, who would be UHC 2.0? That would mean we would, of course, use those freed up resources in health personnel, in service delivery, and of course in finance for those people who really need it. And these are the people with rare diseases. So colleagues, when we're talking about priority setting in a very difficult environment in which we are at the moment, I think we need that mind shift. And rare diseases can help us to get our compass right in global health. That is why I'm so enthusiastic about this resolution, because it really shows us what the world really, really needs. Looking then at the opportunities, isn't it a great time? The opportunities that arise through technological innovation. The opportunities that arise because colleagues from the industry are looking out for the next innovation in pharmaceuticals. The advances that we're making in genetic testing. There's a lot of innovation happening that we can then use for the benefits of the families and their for the patients and their families. Now, thank you so much for this video. Fantastic. Because it really brings life to a public health theoretical problem. It is the people out there that need us. And they need our understanding of public health and the opportunities that we have in public health now to actually make diagnosis faster and to attach therapies to the diagnostics. That is what we now need, and what we can. And that's the fantastic news in public health. We can do it by centralizing the expertise. Because of the rarity, of course, we need then to centralize the expertise that we have around the world. We need to find and work on opportunities so that the health professionals, wherever they are in those centers of excellence, can talk to those people who are caring for the people who don't know what they have through diagnostic trees, through artificial intelligence that we can use to really then focus on what sort of group of disease could this patient belong. And then we could we could link that to the center of excellence, who then would perhaps be able to diagnose a person so much faster. But for this, we need to think outside of the box. The first thing that some of colleagues in public health then tell me is that, but that means that somebody sitting in country X would do a service for somebody sitting in country Y. And with the health financing modalities that we have, that will not work. That, colleagues, is a challenge that we need to face and resolve. There can be bilateral agreements. There can be agreements between regions of countries to actually take over the costs and share. It's not it cannot be another trust fund or so, because we're talking about 300 million people who need that care. So we need to have sustainable structures how we remunerate the services being done cross-border. That can be done. We've done it in other ways. So why not translate this knowledge that we have in agreeing on cross-border financing to and apply it to people with rare diseases? That is an innovative thought, and if we're thinking big and for a medium term, let's look into the next 10, 15 years, I bet if we're behind it, we can do it. Because in the end, it's all about political will. It's not that we wouldn't have the instruments. It's not that these things would have never been done. It is to apply the knowledge we have to the issue of rare diseases. And that, again, is the way that rare diseases help us find in public health. It's not the corner. It's not the sideline. It's the center where you have to be. And that is why I'm so enthusiastic. You see it. I'm really emotional about this, because we see that something is possible. There's a technological way of doing these things. It's just that we need to do it. And that is why all of you are so important here, because it's great to be in Geneva, it's fun to be at the World Health Assembly, but each and every one of you carries responsibility. We're really gifted. We're the elite because we're here. But that goes with responsibility, that we, wherever we sit, whatever role and function we have in our governments, in our societies, we need to advocate for that. And we need to help implement this path. That is, I think, something that unites us. And I must say, when I started thinking and seeing, or thinking about rare disease and what we could do in public health, and seeing the lives and hearing more about the stories, I think that this is, once you're in there, you're attached to it. So while I will retire from WHO, I will not retire from my work with rare diseases. So let us celebrate. It's been great to have this path of the journey as a milestone, but there's a long way ahead of us to make really the life of people with rare diseases much better than it is today. Thank you very much.
Thank you so much, Dr. Krush. Every time you speak, I learn something new. And the rare disease community is really so lucky to have you as an advocate within the WHO. So now we're actually going to segue into our first panel discussion. So to do that, I am very honored to invite Dr. Ritu Jain, the Secretary of Rare Diseases International Council, to the stage to introduce our first panel.
Thank you so much, Ilana. Thank you. Good evening, and it's wonderful to see the rare disease family come together. Thank you for joining us this evening. I am pleased to introduce our two panelists today, starting with Dr. Jerome Weinbach. Dr. Jerome Weinbach is the Deputy Director for European and International Affairs of the French Social Ministries, which include the Ministry of Health and Prevention. With extensive and rich experience in rare disease research, Dr. Weinbach currently leads the European joint action aiming to maximize the impact of the European Global Health Strategy. So, welcome, Dr. Weinbach. It's lovely to have you with us. And our next panelist is Dr. Adiratna Matripan. Dr. Adiratna is an immunologist currently working at the Institute for Medical Research, National Institute of Health in Malaysia. Dr. Adiratna's research interests focus on immunology. She has special interest in rare disease, cancer, and immunotherapy. So let's welcome our panelists. And thank you. So I have a few questions for our panelists, but I do hope that you will have questions for them as well at the end. So I've got some time saved in our panel for that. So moving on to the first question I have for you both is, as we advocate for integrating rare diseases into national health strategies towards achieving universal health coverage, what practical steps would you recommend to countries that are seeking to initiate or establish or scale up effective rare disease frameworks? Dr. Weinbach first.
Thank you very much. So first of all, a big thank to RDI for its tireless advocacy for bringing the rare disease topic high in the global health agenda. This is extremely important and very beneficial for all the discussions we had since the WHA started. Well, France has a long experience, 22 years now with the first rare disease plan, national plan. We launched recently the fourth plan. We've learned a lot. It's improving. But there are still many gaps and weaknesses to improve, and we need to learn also from other countries and regions of the world on their experiments and to exchange on the bottlenecks to make sure that those who are starting to establish national plans will avoid some mistakes that it's normal that we made in the past. So the new plan is structured around 4 main axes. The first one is improving well, I would say the care and life pathway, and life is very important because it also includes the social dimension of rare disease, access to school, to jobs, decent jobs, etc. So it's very important, and of course, social protection. This is extremely important. Don't make rare disease only a biomedical topic. This is much larger than that, which is interesting when you are working for 4 different social ministries. This is what I learned since I am there. I mean, if you don't have national plans, start humble, but start to launch a plan with clear targets. Even if the targets are humble, I mean, that will be improvement for the care and life of this patient. What we did 22 years ago, this is to establish expert and competence centers in France, making sure that all subnational regions had at least one expert center or that could address, you know, the families and rare disease patients to the right expertise and resources. Then we built, with the second and third plan, national networks. Today we have 23 networks in France, well, specific rare disease families networks. That was also very useful for improving the care pathway of the patient, making sure there are also good information with doctors, including GPs, nurses, etc., that are not necessarily from the rare disease field with the expertise, but making sure that literacy is improving also in the health professional community. Very important. Then we moved to the European and regional dimension based on this experience with our neighboring countries and other EU countries, developing the European reference networks. That was critical and very interesting platform also to perform research and innovation, because as you know, sometimes the number of patients are not sufficient in a single country. But that was also very important at national level to promote standards. You know, our hospitals 22 years ago, they were acting like a fortress with their own standards in registries, patient registries and so on. That was not satisfactory. So the regional dimension helped a lot. Also the health system, the national approaches to break the silos between hospitals, between also the patient association and the specialist and the research community. That was extremely important. The new plan, the fourth one, which is called From Territories to Europe, I could translate for any region of the world from local to global or regional. It's extremely important. As 4 pillars, very briefly. So improving the care and life of patients, improving diagnosis, early diagnosis, that's essential. So once you have this care pathway and resources, integrated resources, you can improve the access to diagnosis and reduce the time before you're diagnosed with your disease. The third pillar is on research and innovation. Once you have established these platforms, you can perform with sufficient power very interesting studies and trials where the patients, their families will be involved actively, the association to design the studies, to define the right endpoints, but also to conclude public-private partnerships where a company, a pharma or a smaller company will be very happy to access to integrated and large resource for trials that will be conducted by the public hospitals and the patient association that will please also the regulators and the regulatory authorities, I would say, at national level. And the last one also concern data. That's a treasure that these networks can then improve data collection and the potential of AI, for instance, and many other tools in this data-rich environment will be much more efficient. I stop here. So even if your capacities as a country are limited, with clear targets, with objective, and probably quicker than we did in France, because with our partnership, you can avoid to do the mistakes we did in the past. You can achieve a lot. Thank you.
Thank you so much. That's really incredible. Indeed, it's not just a biomedical topic, but a social and life journey initiative and effort. And really, thank you so much for sharing us the French example that can be scaled up in a shorter time with greater impact. Thank you so much, Dr. Adiratna. Any gems from you, particularly Malaysia is at the forefront in the ASEAN region, and you're forging the way ahead. So
thank you very much. So thank you very much to RDI for this invitation to speak over here. For Malaysia, we are still very young at this area, but what we have, and maybe I can share what we have done so far, is that we have launched our policy on rare diseases. And although they still are not perfect yet, but we know that what we need is a good action plan for this. And when we look at, rare disease, and when we talk to our, headquarters of Ministry of Health, they will always ask, why rare disease? Because we have so many other diseases, and why rare disease? So we have to tackle that question. And we look at the ecosystem of rare diseases. We know that diagnostic odyssey, diagnostic delay, and the management of patients, and also the access to drugs, expensive drugs, and other supports as well. So when you look at that, we have identified that it is not just rare disease. Perhaps we can look at the bigger area, which is precision medicine. Mm-hmm. So what we did was we engaged with many ministries and parties and ask them about this area, precision medicine, and how do they think about this. So, and how to solve those issues, particularly for rare diseases, but we have it under the umbrella of precision medicine. So for the past 5 months, we have been looking at that, and we have drafted a cabinet paper for precision medicine, which we know that rare disease will definitely be benefit from this effort. So that is how we have been, doing, and we hope that this cabinet paper can be approved soon. And in that case, I think with the anchor in precision medicine as well as rare disease, we hope they can get more access to better diagnosis, and earlier diagnosis, and better treatment, and better access to drugs.
That's very exciting. Thank you so much. Precision medicine is indeed the way to go. Let's hope there are. Let's also hope it follows with budgets for therapeutic access. Thank you. I have another question for you both. On Monday, day before, we heard from Dr. Jeremy Farrar of the WHO that political will is necessary to open the door. And if we see the resolution as having opened the door, then what mechanisms would you say are necessary for translating this political commitment into positive change for long-term impact? And you've already alluded to some of that with, what you talked about, the 4 pillars, but would you be able to expand on this, please?
Yeah, first of all, well, I do agree with Jeremy Farrar, but I would not formulate exactly that way. Well, political will is essential, but it must be sustainable, first of all, very important. And there should be no door to open. There should be no door at all. I mean, that's the principle we need to reach. No door to open, because if you open a door, it might close again. So we don't want doors anymore. You know, in France, well, in French, but I think in English too, patient means someone waiting with hope. Hope is nice, waiting is not nice, and that's very important. The day that the rare disease citizen will be called citizen with the same rights to access to diagnosis, treatments, research trials, research and public health studies as well with their family. The day there will be no burden anymore neglected by the policymaker, there will be no door anymore. So that's the main thing. And if you want to achieve measurable long-term impact, just ask to the patients or the families if they are still called patients. Just ask if they are happy to be considered as normal citizens. Same with the doctors, the nurses, the caregivers, the family caregivers that are acting on a daily basis to support our rare disease citizens. Thank you.
I absolutely love that. I think all of us in the audience here today agree, especially we parents of children with rare diseases. And we look forward to the world with no doors and no waiting, and citizens of a state, not patients. Yeah. Thank you, Dr. Adiratna.
Well, now you talk about sustainability,
yes.
Right? Right. So in a country like Malaysia, we are a very small country, yeah? So finance will be one big issue.
Absolutely.
Yeah. So what we see is that we have got a real good partnership with industries. We think that is one potential way of having it more sustainable. And at the same time, we think that we need to have a good registry. That is something that we can probably give to the policymaker and say that, oh, look, although you say it's rare, but then when you look at collectively, it is not rare. So, with that kind of push coming from patient advocates and also from us who's doing the research, I think we also need to come up with a certain plans, for example, to look into financial burden and the cost effectiveness of having these patients diagnosed early and having good therapy like gene therapy, for example, and that can cure the patient. So all that, whatever we do, we collect the data and prove that this is the way forward. And we hope, we haven't done much, but we hope that can sustain.
We hope so too. All of us collectively certainly hope so too, and we'll be cheering you on. I have my final question, and before I turn over to the audience for their questions, how can collaboration in your regions, Europe in your case, ASEAN in yours, accelerate access to diagnostics, data sharing, clinical trials, and affordable therapeutics at the country level? And Dr. Kresh also alluded to bilateral regional agreements for sustainable cross-border change. Mm-hmm. So is there hope? Can we replicate the European Union example to the ASEAN region?
Absolutely. And again, even if we don't have the same resources, structure of health system, structure of social protection, whether you are a citizen in Asia, in Latin America, or in Europe, the fact that you may set up multinational networks that are so needed for research purpose, sharing of practices, protocols, expertise, access to information, literacy, training. That was essential for Europe, but that's exactly the same elsewhere. So particularly when you are lacking of resources and trained doctors and clinicians, when you build at regional level, you mutualize resources, expertise, and you can increase the critical mass which is necessary for performing anything you want, anything you dream of. So, and you will be supported by your neighbors and your partners. I want to say that certainly rare disease in Europe and the way we established the European reference networks did change what we wanted to build, the European Health Union. That was at the forefront, the initiator of the building of the European Health Union. I remember the e-health network that prefigurates what we call today the European Health Data Space. This is thanks to the rare disease citizens and doctors that were involved in the building of the European reference networks on rare disease. This is just one example. The economic model where research and care are so close in the rare disease field, working together also in public-private partnership. This is a unique experience that will and can serve many other neglected diseases, including infectious disease in other regions of the world. So this is always the premises of what we want to achieve for the global health and global health system strategies. Thank you.
Thank you. I really like that. I think that is very much possible to replicate. It's not just finance, but it's the frameworks for literacy training and achieving critical masses for scaling up. Thank you. Dr. Adi Ratna, your response.
Yeah.
Would you say,
yeah.
Dr. Weinbach?
I concur with ASEAN. We really have high hope with ASEAN and also APEC, the whole Asian Pacific. So we think that putting them together, and then what we had yesterday was really good, where we had Jerome talking about French experience and China, India, and from there we hope that we can get and adopt the best practice from each country. And we also have already started engaging with Southeast Asia, the ASEAN countries, and identified what are the gaps, what are required, what is needed in this region. And we have identified similar things as what Jerome has also identified: lack of human capacity in certain areas, access to drugs, orphan drugs, for example, all this. So we think that being ASEAN together, maybe, for example, we can have clinical trial across the whole ASEAN, because it's rare. We probably have only a few in our country. So let's think about it as a bigger region, and we hope with that we can get buy-ins from the industry, to come and do the clinical trial in our area. So there's so much that we can do. We have our own registry in ASEAN, for example. So that is something that we really look forward. But yeah, we hope that we can achieve.
We hope so too.
May I make an announcement as well? Should not be only on therapeutics. Well,
exactly.
Treatments are needed.
Yes.
But so many rare diseases do not have yet treatments. I want to say that we are launching a new project with WHO Euro as well on non-pharmaceutical interventions. They are extremely important to alleviate the burden of the life of rare disease citizens and their families. Can run from psychomotricity and many, many other things. India, for instance, has the Ayurvedic approach. This is very interesting for WHO. And the families and the patients, they have a knowledge of any kind of solution, non-pharmaceutical solution that could improve their conditions, avoid crisis, and this is a treasure that we need to work on. This is a patrimony of humanity that we want to secure with UNESCO, and this is work done by a friend of mine in Montpellier with a high interest by WHO and WHO Euro. These non-pharmaceutical interventions are very helpful. They are not well known. They are scattered around in families, in city doctors. We need to work on that too. They are not polluting the environment. They don't have side effects, but they are also very important. Thank you.
Thank you. That's really exciting, and coming from my knowledge of the patients that in India and Pakistan, I concur completely. Ayurveda and alternative treatments, I mean, many patients do survive long years without pharmaceutical intervention. So thank you so much. I'd like to, I don't know how many minutes I have, 5 minutes? 7 minutes left. Okay, so we have 7 minutes. Questions from the audience. Yes. Could we have a microphone? Thank you. Could you please identify yourself? Thank you.
Yes. Hi, I'm Jill Klesser. I'm a pharmacist from the United States, but I'm also a cancer researcher, and I'm the current chair of the Orion Data Sharing Network. And my question is for you, Dr. Arinatna. The Orion Network is made up of U.S. cancer centers, and it's a data sharing network where we come together to share germline, somatic, and RNA sequencing data. And I was wondering, as you start off your initiative, if you have considered partnerships with other kind of data sharing networks, because I would say the ASEAN countries are completely absent from any of the data sharing networks that I know about.
Thank you for that question. So actually, we have in ASEAN level, we have thrown that kind of question to them regarding the data sharing. In ASEAN, the data sharing is something very sensitive.
Yes.
Very, very sensitive. And we still need to think, what is the framework, how the governance should be in order for us to share. We know there is a lot of benefit for our patients if the data is shared properly. Unfortunately, I cannot tell you the answer, but we are really looking forward and working towards that, the data sharing, so that whatever that the drugs that you are inventing, new drugs or whatever, it's also benefiting ASEAN. So we are still finding the way. Yeah.
Thank you.
Hi. Is this my...
Yeah, we can hear you.
Okay. My name is Sophia. I'm a French and British citizen. My question is for Jérôme Weinbach. So I'm living in France. I was diagnosed with ALK plus lung cancer last year, and I was operated and treated in France, so I know the French network pretty well. I became involved with ALK plus ROS1 association in France, and I'm working with Valérie Montagny today to further the causes and the desiderata of the association. So my question for you, it actually involves a pathway for recognition of rare diseases. We are about 3% of all lung cancers in ALK+, and we have a roadblock. So my question is, how do we create a better pathway for recognition? Thank you.
Well, today my role is to work on European international affairs, the French Ministry of Health, notably. What I can say that what I learned from inside, that indeed the political will is important, not sufficient, but important. What we are doing with our G7, and part of my team is here and is leading the organization of the Health G7, is to make sure that cancer, including rare cancer, will be very high on the agenda. This is something we can do, for instance, for answering your question. Including during the Leaders Summit in Evian, President Macron has decided to make cancer high on the agenda, which include pediatric cancer, which are always rare cancers, luckily, if I could say, but also cancer with poor diagnosis. And we included also cervix cancer to make sure that women's health will be also high between the leaders during the G7 summit in Evian this year. So this is what we try to do in the limit of our functions and duties, but this is something important. Of course, we have to work with the communities as well, including researchers and clinicians and patient associations and legislators. The parliamentary chambers, we need new champions for rare disease. If we lose them, because there are elections and they are changing all the time, the budgets will be not few where they should be targeted to.
Thank you.
Yes, hi. I just have a question. Can you guys comment on how you think population genome sequencing programs may be able to improve equity in genetic healthcare?
Could I request your identity? Could you introduce yourself, please? Thank you.
I'm sorry. My name is Weibin Liu, and I'm Vice President at BGI Group. I'm also one of the lead architects of the Human Genome Project, too.
Thank you. Did you get the question?
Yeah, I got the question.
Would you like to take that?
Yeah.
Please.
Okay. So, population genomics. We are happy to share that we have started population genomic work since 2024. Although it has, it's escalate. The numbers are still very small, but we are going to extend that population genomics as in how to guide us for the precision public health strategy for our country, Malaysia. So yes, we think that is very important. For example, for rare diseases, especially for us to understand what is our population like, what is our genomics. Variation, because we have more than 70 different ethnicity in Malaysia. Mm-hmm. So if you cannot base on something that of European countries' Absolutely. Population, right? So we have identified that is one gap that we need to do, and we have started since 2024, and we are happy to say that we are going for phase 2 population genomic work in Malaysia.
Thank you, Dr. Adiratna. I'm afraid I have only 1 minute left, so I can only take a last question. I apologize, but there will be opportunities to converse with the speakers later.
I'm Marie-Claude Boiteux, chair of Cutis Laxa International. I'm also coordinating the citizen representatives in ER and Skin. My question is, we've been talking of registries, data, research. Are you working on interoperability of all systems? Because this is the point. You cannot work today because systems are not interoperable.
May I ask you to take that, Dr. Weinbach?
Yeah, this is absolutely essential, and this is where we are coming back to global health issue with WHO at the center. WHO, in its current reform reflections, focusing on its more fundamental role and duties, and normative role is one of them. You have also health security and crisis management role, etc., and coordination. But certainly, the standards to make sure that when new countries, and I hope there will be numerous, will start establishing registries, that thanks to the role of WHO, they will use the same standards, and that we can work locally, nationally, and globally, or regionally and globally, to exchange data and exploit data for the sake of the citizen and patient. Thank you.
Thank you so much. I'm afraid we've run out of time, but it's amazing to have an audience that hasn't run out of questions. So let's give our speakers a very big round of applause, and thank you. Thank you. Thank you so much. Please. Thank you.
Thank you.
I give the stage back to you, Alana.
Okay. Thank you so much, Ritu, for that, and thank you so much to both the panelists for a really fruitful discussion. It's nice to actually have time on a panel to really think about some of these issues. And thank you as well to all the audience for being so engaged as well. And we will have the cocktail reception after to continue some of those conversations. Now I'd like to invite RDI, another council member of RDI, to introduce our next panel discussion. So without further ado, I'd like to invite Diego Fernando Gil Cardoso to the stage.
I'm going to be in the podium. Sure. I prefer to stay in the podium.
Yeah, of course.
Okay. Thank you very much. I prefer to stay here in the podium because I can see the panelists better. And thank you. It's an honor to be here, not only as a patient, but also as a member of the council of RDI. This topic is very important, especially in my country. At this time, we are facing the most critical crisis at financial level, because we have had many patients that have died because of the lack of treatments and because of the financial or political decisions. This situation can't happen to any patient in any place, in any country. It's important that we join efforts to change, to transform this reality. Rare diseases often show us where our health and social systems are not yet working as they should. But today, we are also want to look at rare diseases from another perspective. We want to see this perspective. We want to see rare diseases as a source of solutions. This is important in this panel. In this panel, we will focus on three questions, three specific questions. The first one, what is already working in some countries? How these solutions can be scaled, and what financing and partnership models are needed to make them sustainable. Let me briefly introduce our panelists. First one, Anne-Sophie Chalandon. Anne-Sophie, please. Anne-Sophie is the chair of Rare Disease Group of IFPMA, the global federation that represents the innovative pharmaceutical industry. Thank you, Anne-Sophie, for accepting this invitation. Hada Mounif is the founder and head of the board of trustees of Forsted Hayat Foundation for Rare Diseases. Thank you, Hada. Claude Meyer is the senior advisor at the P4H Network, Department of Health Systems Performance, Financing, and Delivery at the World Health Organization. Thank you, Claude. And finally, my friend and colleague, King Ping Sang. He is the co-founder of the Hong Kong Rare Disease Collaborative Network. His work is strongly shaped by his lived experience as a person with retinitis pigmentosa and by decades of advocacy. Thank you, KP. Okay, I want to start our discussion with KP. KP, what rare disease solutions are already helping to strengthen health and social systems, and how can patient-generated knowledge and lived experience help scale these solutions?
Thanks. Thanks, Diego. Firstly, the rare disease patients have pioneered the referral pathways, multidisciplinary case management, and also coordinated care pathways. These reduce the fragmentation and delays. That's also helpful to strengthen the health management for some chronic and complex disease. The second thing is just we heard from the French ministers that not only watch the biomedicine, for rare disease patients, rare disease affects also the education, employment, mental health, and the daily living. So always the support schemes bridge health and social sectors. So this model also help to elevate the quality of universal health coverage, to keep the people's health in a holistic way. And the third point is that in rare disease, always the patients have participated in the policy debate and policy design. So the system, the health system, if we have the patient's engagement, patient's involvement, that would be an effective and trusted system. That would also work for other disease and for the whole health system. Another aspect is the multi-sector collaboration. For rare disease, that's very natural that the collaboration between the clinicians, scientists, industries, and the philanthropia and the civil society. This is also helpful for the healthcare reform that's needed for further reform for the healthcare system. So these points shows that what's happening in the rare disease also helpful to the strengthening to the healthcare system and to improve the healthcare system. For the lived experience, I think the first is to get patients involved at every level and all points of the healthcare settings. If the patients is engaged in the healthcare settings, that would help to build up more effective and trusted system. The second thing is standardize. To standardize the data and the coding, like ICD-11 and the standardized format of patient-reported outcome, that would also bring the lived experience into the system more effectively. And the final thing is the governance. If we have robust governance, the patients have trust to the system, and then also the scientists can access to the data base to do more research. That would be helpful to both the research and also the patients. So good governance is also a very important point for lived experience that works in the strategy for the national strategy for rare disease. Thanks.
Thank you, KP. Very important. This perspective from the patients, the holistic perspective, and especially the importance of the evidence for the decision making. I want to move to Ghada. In your opinion, what practical lessons from Egypt could help other countries to move from isolated responses to more coordinated and escalated or scalable actions?
The most important lesson Egypt teaches us is simple. When people unite around a cause, the impossible becomes possible. It all started with one child, Rashid. His medication cost $2 million, equivalent at that time to 35 million Egyptian pounds. which was far too expensive for his family alone. But a small idea changed everything. If 140,000 people each donated 250 Egyptian pounds, we could collect the full amount, and we did it in 18 days. That moment proved that no child should face their battle alone. What started with one child became a movement where small act of kindness multiplied by many created something much greater than any one person could achieve alone, and that is what turned a simple act of kindness into a national movement in Egypt. So that's how it started, all the rare disease in Egypt.
Okay. I think it's very important that every patient could have the same opportunities than any other one. That's very important. Thank you for sharing that, Gada. And Sophie, from your perspective, from the pharmaceutical industry perspective, how can innovation in rare diseases, including diagnosis, data, evidence generation, and treatment pathways, contribute to a stronger and more equitable health systems?
Thank you for the invitation. Thank you for inviting industry on the scene, and thank you for the great question. And I think this is really an important question. And I would say that if we want to be globally more equitable, we need to make things globally more accessible. And I will classify my purpose under 5 different categories. First, I think that is something that Jerome said, really important as a baseline. We need to have a global network of expertise. We've got network, we've got experts across the world, but we need to have the good network, to have the good connection, and to secure that this baseline of network will be fundamental for sharing expertise, data collection, better diagnoses, pool resources, knowledges in general. I think we've got really great example in Europe. RDI work a lot on establishing how this global network should look like. We've got the global action plan. Honestly, let's do it. Second, I will talk a little bit about diagnoses. Again, we still have a lot to do on diagnoses. Even in France, this is part of the 4th national plan. You imagine 20 years after the first one, we still have improvement to make. But at the same time, we have developed some symptom checkers. We have developed genomics. We link genomics to AI now to be faster and costly. Again, how amplify that tools which are already existing to some other region across the world? Newborn screening has been developed in the 80s. Newborn screening is not available everywhere across the world. It's not a reason of cost, it's also a question of capacity, but I think this is something that we should expand really easily. And lastly, official global guidance of what disease should be diagnosed at birth. Harmonization of this guidance globally will be really helpful for everyone. I think this is just some ideas, but regarding diagnosis, I think that we can do better if we make things, again, accessible to everyone. Data sharing, I think that it's already raised, also by Jerome, also by our colleague from Malaysia. Data sharing is really important, that this is a baseline for the clinical trial to identify the patient. We are now developing drugs for smaller and smaller population. We need to have global enrollment of those patients into clinical trial. If we are able to know exactly where is the patient, that would be easier and faster. And also, I think that at local level, it's really great to have a clinical trial ongoing. We've got a nice example in Egypt recently. Physicians made an incredible work of collecting data related to a small subgroup of population on Gaucher type 3. We were able to push a clinical trial really easily and fast, and I think this is the way we should go. My first category is related to regulatory frameworks. Adaptive regulatory frameworks treated for small population works. We've got the example in the US, in Europe, in Japan. But we still improve that. Recognition of new endpoints, especially biomarkers. should be there. Greater use of real-world evidence data should be there. Integration of patient-related outcome should be there as well. And then let's also be creative. I'm just raising here the example of Hong Kong, who has recently adopted the fact that at least if a rare disease drug has been approved by the US FDA or by EMA, plus another agency across the world, they are adopting directly the regulatory for the drug. Without redeposing a dossier for the company, it's again a gain of time and a gain of cost. So just be creative. And my last category is regarding access, affordability, and sustainability. And there, I think that we are not there. We all know that. It's the most complex question, but again, few ideas like that. Early access program, enabling early availability, tiered pricing, adapted to countries' economic capacity, outcome-based model, linking payment to real-world benefit, dedicated fund for innovation, humanitarian programs, and philanthropy should be considered as well. And not only one single thing, but I think this is a toolbox. And what about exploring how we can manage, depending on the different situation at country level, to have a kind of balanced share between all those different tools. So again, those solutions must be adapted across highly diverse health systems, but that requires flexibility, pragmatism, and long-term commitment.
Oh, a lot of things. I think it's important to know that there are many important things that are happening. We don't have to reinvent the wheel. There are best practices that maybe we have to reply in different countries.
Exactly. Honestly, yeah. It's frustrating to see that we do dry blood spot for many years and that this is not available everywhere. It's costly, easy to practice. Why?
Thank you, Anne-Sophie, for your perspective. Thank you very much. Now I will go with Claude. I'm going to leverage your experience in financing and social protection. Claude, why are rare diseases a useful test case for universal health coverage? And what system-level lessons can be applied to broader populations?
Thank you. First of all, I know you have done it on purpose that I speak the last one, right? Okay, 2 words of caution. I have never worked for the Ministry of Finance anywhere. And second, what I will try to present this evening is based on research and a project that we have done together with RDI last year in 11 different countries, and you can find this online on both our digital platforms. It's very important to know that this comes from people that are based in the countries. We have joined forces with our networks in countries, the networks of RDI, and what we call our P4H country focal persons that are working on financing and on the social protection. And specifically, we were asking them questions about the coverage of rare disease. People living with rare disease. So the first thing I need to say a bit as the dry person with the numbers is that it is absolutely in line with the principle of UHC, first of all. The coverage of people living with rare disease is by definition a kind of an indicator of taking UHC seriously or not. And it's also based on a mathematical principle that is pooling. Pooling the risk, and you know that when there is a treatment available, very often those treatments are expensive, and if the people are less, this is the basic principle of pooling and of sharing risk. The second one is, again, also on economic dimension, it's on pricing. We found some examples. I think, if I remember well, China was one, where there are practice of differential pricing, of price reduction, that is negotiated, and that is really a very important indicator and a very important factor of reducing the bill at the end of the day for the whole society. The third lesson, or I would say observation, is that it's very important to connect the financing mechanisms with the service delivery design. And I know that many have already been mentioning the detection, and especially early detection and screening, etc. You can put financial incentives behind. The best practices are the places where those financial incentives are there. Then, and I will also quote Jérôme, sorry, but we also found that it's not about healthcare services only, and that the non-health needs are particularly important, and that this needs also public funding, not only the health services, but what we call social care or other dimensions of the needs of people living with rare disease. And I just wanted to mention in relation to this point that we have also a WHO resolution that is called Economics of Health for All, that has been adopted last year, 24, and that is also looking at public investments that are important for the improvement of health status, but that are not on health services. So, and there is also a dimension of cost-benefit analysis in those areas. It's not only for the health services. And finally, many of you have already been talking about data and standardized registries, etc. There is one thing that we really found out worldwide, and even in the most advanced countries, there is no data about the financial hardship that is experienced by the people living with rare disease. Those figures do not exist anywhere, even in the most advanced countries. Thank you.
Oh, very important. Thank you, Claude. We've heard about knowledge sharing, data, evidence, early diagnosis, social participation. I want to connect with something that is very important, and the resolution also mentioned it. We have to face the challenge of transforming our rare disease community, not only beyond the medications, beyond the treatments. We need to face the other challenges in reference to the social protection. KP also mentioned that, so it's important to have this holistic view. Now I want to move to the other part, also very important. We discuss about the sustainable financing and partnerships. I want to start with you, KP. What conditions do you think are needed to ensure that financing and partnership models are transparent, sustainable, and truly centered on the needs of people living with rare diseases and their families?
Firstly, the most important thing is the government's commitment and long-term planning. And the resolution passed last year at the World Health Assembly, and also the Global Action Plan to be developed in coming years provide a framework for the long-term planning. Also, national strategies in the countries ensure the continuity that beyond the policy cycles. The second thing is public-private and patients partnerships, PPPP. We know rare disease shows no single actor can carry the burden alone. So the PPPP is also important to make the investment in the diagnostics and also R&D for the therapies and other holistic care for the patients. The third point I would say that is the collaboration. And, the rare disease patients is a small number in many countries, in particular for some low and middle income countries. So the collaboration, likely the pool procurement, share registries, and the collaboration of the Center for Excellence, in particular for the low and middle income countries, will be helpful to make better use of the limited resources. And the other thing is value-based agreement on outcomes, performance, pricing strategy, and these would help to balance the innovation and the affordability. And the last one is to fund the patient groups and the patient organizations and peer groups, because the rare disease patients are most important partners in the field. If we can support the development of the patient organizations, that will be ensuring the robust and the sustainability of the rare disease programs and works. So this also good value to invest in patient organizations. Thank you.
Thank you, KP. Very important. Very important. I really support that part, everything, but that part is very important because it's an additional challenge for the patient advocates. Face the challenge with the sustainability for in their own organizations is very important. Thank you for that, Kada. In many countries, families still depend on emergency fundraising or fragmented support. What kinds of partnerships are needed to reduce the financial burden on families and make support more predictable after diagnosis?
Early diagnosis is not just a medical achievement. It's a child's first chance at survival. The first step starts with expanding newborn screening, because I believe it's really important, which plays a vital role in ensuring that conditions are identified from the very first days of the child's life. Awareness also is very important, and early detection become essential. Many families do not recognize the early signs of rare diseases, which is why training doctors and nurses to spot warning signs early can make a life-saving difference. Today, also, technology is taking this even further. AI tools like ThinkRare to scan patient EHR data and flag individuals for genetic testing, making it possible to catch rare diseases earlier than ever before. The second step is making sure that once a child is diagnosed, they are not left to navigate the system alone. A dedicated care coordinator, someone who guides the family through treatment, appointments, and support services as well. The third step in connection, hospital specialists and community organizations must speak to each other. Because you know what, now when the families know that their kids have a rare disease and they don't know how to deal with the system, they don't know where to go. Like, unfortunately, in Egypt, we don't have still a center of excellency, so they don't know where to go. So this is very important that they have a place to go to. When information is shared and care is coordinated, children receive faster, better treatment. Today, platforms like Swarm Learning model makes this possible, allowing institutions to share patients' data securely while protecting privacy. Together, this approach can reduce the time to diagnosis from years to months, giving children a real chance at treatment and better outcomes.
Great, thank you, Gada. Very important. It's important that all the stakeholders build trust. in order to provide the support, the whole support, the holistic support to the patient and families. It's very important that the families can't be isolated facing all these challenges. Thank you for that. And Sophie, looking toward the global action plan, what types of public-private collaboration could help countries move from innovation to sustainable and equitable access, especially when we are facing budget problems and technical capacity are constrained in many countries? So, what do you think about that?
So I will multiply the P's of KIPI. The person in the room who knows me know that I love to speak about the 6 P's. This is public, private, patient, PAGs, payers, policymaker partnership.
Wow. Again.
Again.
This is copyright.
Public, no, I'm sharing everything. Public, private, pooling resources. This is the purpose of the question. So, public, private, patient, PACs, payers, policymakers, partnership. Patient association group, PACs. I think it's really important to have. And I think it has already been raised by everyone, Claude, Jerome, Kipi. Partnerships are everywhere. I think this is in the DNA of rare disease community. We start really early, 20, 30 years ago, to start by collaborate and to establish those public-private partnerships, and they have been really amplified. Which is really good is that now we've got, through the latest publication from Together for Rare Disease Initiative, we established really a safe place and rules of collaboration for those 6 P's partnerships. And I think this is just a good model that we can really use, easy to use, easy to go at each time of the need, from data sharing, clinical trials, screening of new molecules. We've got plenty of good examples. Radico is a good example, really precursor. The latest EHI realized the project. We've got example in the development of IE tool for diagnosis. So I think that pulling all the actors together, pulling the resources, pulling the knowledge, pulling the willingness as well is essential. But for me, the key thing is that to have everyone at the table sitting since the beginning, because that creates acceptance of the project and that gives better result at the end. Right. So for me, it's really my key takeaways for public-private partnerships. On access to rare disease drug, I think I already raised that, and Claude, you mentioned some pooling at regional level, the number of patients, because that could have an impact on price, this is sure. Again, tiered pricing, country fund for innovation, humanitarian program, philanthropies. I think that all those small tools putting together, depending on the local situation, could be helpful, but we need to have really this toolbox, and this is where we are really rating something coming from the Global Action Plan. This is, for me, that would be really the things to work on, because we do not have a clear solution yet.
Okay, great. Thank you very much, Anne-Sophie. Very important, and I think it's feasible because we have many best practices that are in progress now. So it's important to reply that not only in every country, but also in the different regions. So thank you for that. And finally, Claude, it's a tricky question. How can countries move from case-by-case funding decisions for rare diseases to more predictable, fair, and sustainable financing arrangements within broader WHA reforms?
It's a very good one for me, that one.
The last one.
The first thing I wanted to mention is that in this research or joint work that we've done last year, it all started from our colleagues in Kazakhstan, because in Kazakhstan they had set up a kindness fund, if I remember well the terminology, and the person that was also at the same time our P4H country focal person was saying, is that not a great model for the world? My answer is no. Sorry. It's always a good idea to find additional money, of course. But the problem is how you organize it. And on that side, I have to say that our department in WHO is very clear. We would like to have the pooling at national level for everything, including rare disease, and not a specific fund aside. We know that when you create those kind of funds, you also trigger a path dependency. And it's extremely difficult after that to actually sustain the funding. That is your question. Okay. So I would really not recommend, and we would not recommend, to follow that path, even if it looks very attractive at the beginning. Okay. Yeah. Okay. Of course, you have to include in the benefit package of your general system, of your general coverage system, and you have to include the costing. And this is where, of course, it gets very tricky. I'm going to talk about the low-income countries just after. Second point is that, please, another no. I'm sorry, I start with 2 no. Please do not start specific investment cases for rare disease. The mushrooming of subsector in health, I mean, of subsector investment cases is something that is not welcome by ministries of finance or by the highest authorities. They will have a pile of 17 or 25 different investment cases. It's not a good idea. It's better to have it included in your general investment case, showing the return on investment in qualities and rare diseases included in the general calculation. Third point, and this is where we go to the tough, very tough part. When we have done the study together, I look at you, Alana, because you know this very well. The most, like the low-income countries, we were in the total, we were blind. There was no data, there was no policy, and there was no money. So in that case, what I'm saying before is completely theoretical. Mm-hmm. So in that case, we need to talk, and I think it was mentioned already in the previous panel, we need to talk about multi-country pooling. And that's especially for small countries, but also with the principle of international solidarity with low-income countries, because we have seen that in the low-income countries, they can't. It's very simple. There is no fiscal space, even for basic other things. So you cannot apply this same logic for this category of countries. And I wanted to say that we also face, at the moment, and this has been also documented by my department, a health financing emergency worldwide, with cuts, especially in the low-income countries. So the only logical solution is a pooling at an international level. Now, I'm not saying how to do it. It's always also a very complex question. There are debates about the global fund, and it's not an easy one. But really, in terms of health financing, that's what is recommended for those type, this type of countries. And the last one, I don't want to repeat, but of course, that's what we've tried to do last year. It's very important to have exchanges at regional and global level, just that the other countries know what is implemented in the neighboring countries or very far away, because in terms of financial coverage of rare disease, it's not well documented so far. Thank you.
Okay, thank you, Claude. Very important. Thank you for landing us with these important issues, because sometimes we always try to evaluate different strategies for the sustainability, for financing rare diseases, and it's important to avoid mistakes. We have many lives inside these decisions. Thank you for that. Do we have how much time to finish? No, we don't have time?
One sentence closing question.
One sentence, okay, perfect, perfect. Finally, please, in less than 1 minute, I prefer to do it, in less than 1 minute, what should the Global Action Plan make possible for people living with rare diseases by 2038, at the end of the implementation of the Global Action Plan? I'm going to start, please, with Claude.
Yeah, it's very much about money in my case, and that money is tight. Mm-hmm. There is competition in all categories of countries. There is a surge of defense expenditures, of security expenditures. Mm-hmm. I think I want to go back to the very beginning. Those testimonies are very important, and it's important to show them to the decision makers, because you need to touch them, not only talk about money.
Great. Thank you, Claude. Anne-Sophie?
4 things. First, global network of expertise. Second, global and harmonized diagnostic guidance and capacities. Third, global regulatory approval for certain category of rare disease drug, really helpful for low and middle income countries. And then a work on access, and I think that Claude just raised some really key points on global access and global funding, so let's work on that.
Thank you, Anne-Sophie.
So I will not just repeat what they were saying. I will just add something. I believe that the government needs to lead with the structure support as well, through national coverage and detected treatment funds. Pharmaceutical companies need to offer fair pricing and a compassionate access program, and the private sector needs to move beyond one-time donation and commit for a long-time support, even if it's with small amounts of money.
Thank you, Gada. Finally, KP?
When we design a system for the most underserved, we are building a system that is more equitable, more resilient, and better for everyone. Thank you.
Thank you, KP. Thank you very much to all our panelists. What we can take from this important conversation is that rare disease solutions are not only rare diseases solutions. They are health system solutions. We are improving the life not only for the people that live with rare diseases, we are solving the problems for all the people that live in the world. Thank you.
Okay, wonderful. Thank you so much. Really, really enriching discussions tonight. Thank you so much to all the panelists. And also, maybe I'll take another opportunity, since we had the co-hosts on stage, just to thank again the 3 organizations that were co-hosting this event. All the support is really critical to make discussions like this happen. So now, to complement everything that has sort of been said so far through the keynote remarks and through the panel discussions, we want to make space for some other critical perspectives, and those are from the rare disease youth community. So now I'd like to welcome a member of the Rare Disease International Youth Leadership Program, Tony Roberts.
Bonsoir à tous. Good evening, everyone. My name is Tony Roberts. I am actually half Swiss and South African, and I live with epidermolysis bullosa, which is a rare skin condition that has shaped much of my life and the majority of my purpose. Before I continue, I just wanted to mention, so often when you're invited to speak or to put on a presentation, generally our sort of second slide is a conflict of interest or disclosure slide. So I thought I just wanted to disclose that perhaps I'm not the most credible youth representative in this room for a number of reasons. First, growing up with a rare disease has a way of fast-tracking you through childhood. When you've navigated medical systems, insurance disputes, and treatment decisions from a young age, you skip a few developmental milestones. Second, the condition I live with is degenerative, which means that on most days I feel less like a young person and more like a retired grandmother. Third, I also live with quite severe other chronic conditions, one of them being endometriosis, which has unfortunately triggered early perimenopause. Fourth, I regularly walk into rooms with ambition and purpose, and often absolutely no memory of why I have in fact walked into that room. So I retrace my steps back down the corridor and wait patiently until I remember why I walked in there. I feel like I could name a number of those. I currently have an eye abrasion, so you can also maybe see me doing one of these, that kind of thing. So I stand here feeling a little bit like a fake youth, but by most biological and neurological measures, and yet here I am. Because the truth is, this is exactly the point. Young people living with rare diseases are not living standard issue young lives. We are navigating complexity, uncertainty, and systems that weren't built for us. We're doing it early, and we're doing it anyway. Today, I'm proud to be a part of the first Rare Diseases International Youth Leadership Program, president of the DEBA International Youth Council, and coordinator of the Global Skin Young Patient Leader Council. Across all of these places, one thing has become very clear to me. Young people living with rare diseases are not just the future of healthcare conversations, we're already contributing them meaningfully at the moment. As you've heard, rare diseases affect more than 300 million people globally, and many of those affected are children and young patient leaders. Too often, youth are invited into discussions only after priorities have already been set. We are asked to share our stories, but not always to shape the systems, policies, research, and programs that directly affect our lives. But young people bring something unique. We bring lived experience that is current and immediate. We understand what it means to navigate education, employment, relationships, independence, mental health, and transitioning into adulthood, while also navigating healthcare systems that often were not designed with us in mind. We also bring creativity, urgency, innovation, and long-term vision. Many young people living with rare diseases have spent their lives adapting to inaccessible systems, adapting to delays in diagnosis, adapting to uncertainty. That resilience creates leaders, problem solvers, and community builders. But resilience should not be the requirement for participation. Youth should not have to fight to be heard in spaces where decisions about our lives are being made. If we truly want stronger and more inclusive health systems, then youth engagement cannot be symbolic. It cannot be a checkbox. It must be meaningful, ongoing, and embedded into decision-making at every level. That means creating space for youth, and not only in advocacy spaces, but also in research, policy development, program design, and implementation. In many ways, this reflects the broader conversation that we've been having this evening around rare diseases and global health transformation. When we build systems that respond to the needs of people living with rare diseases, we create systems that are more coordinated, inclusive, accessible, and resilient for everybody. Rare diseases expose the gaps that already exist in healthcare systems, whether in diagnosis, access, equity, or continuity of care. And by addressing those gaps, we strengthen healthcare more broadly. Youth engagement is an essential part of that transformation. Young people living with rare diseases understand firsthand where systems succeed and where they fail. Including youth perspectives early helps create healthcare systems that are more responsive, future-focused, and grounded in the reality of patients' lives. It means recognizing that youth perspectives are not all the same. A young person living with a rare disease in South Africa may face, and does definitely face, very different realities to someone in Europe or North America. Geography, income, disability, language, culture, and access all shape our experiences. And yet, despite those differences, many of us share common challenges: delayed diagnosis, isolation, mental health burden, financial strain, and difficulty accessing care. This is why global collaboration matters so much. When youth from different regions and backgrounds come together, we don't only share challenges, we share solutions. We learn from one another and we strengthen one another. I have seen firsthand what happens when young people are trusted with leadership opportunities. I've watched youth-led initiatives create real impact in awareness, peer support, research, engagement, and community building. I have seen young people transform pain into purpose and isolation into connection. But these opportunities still remain limited. So today, my call to action is simple. Do not engage youth only when it's convenient. Engage youth because health systems are stronger when we are included. Create spaces where young people are not just present, but valued. Invest in youth leadership, especially in low and middle income countries where opportunities are often limited, despite extraordinary potential. And most importantly, involve young people early, before decisions are made, not after. As the youth of today would say, you know, there's been amazing topics spoken about this evening, such innovative ideas, mentions of collaborations and continuing the conversation. And something that's often said is, you can slide into my DMs so we can continue the conversation. Merci beaucoup. Thank you.
Thank you so much, Tony. And I know some of the other members of our youth leadership program are with us online, so thank you to all of you for the work that you do and all the members of the rare disease youth community as well. Now we're going to start closing down the event shortly. I think we'll probably finish around 8:15, if that's okay for everyone, and then we will move to the reception. So first, I'd like to introduce our closing keynote address. So to do that, it is my honor to invite to the stage the Secretary of State for Health for the Kingdom of Spain, Dr. Javier Padilla.
Hello, good evening to everybody, and thank you very especially to the speakers and also to all the organizers of this event. It's 1 year now that the resolution about rare diseases was approved, the resolution that was co-led together by the Egyptian government and the government of Spain, and I want to thank and to stress this thankful to the Egyptian government. But it's a resolution that we should recognize that it was not our idea. It was the idea and all the work together with the Rare Diseases Organization trying to put the focus and to put all the center of the ideas on this ground. Now, 1 year after that, we should be calling for action, and we should be calling for this global action plan on rare diseases to be materialized. Rare diseases is one of the central dimensions for universal health coverage. When we are talking many times about universal health coverage, we think of undocumented migrants, we think of refugees, we think of many people. But rare diseases and really addressing the actual needs, not the theoretical needs, of people living with rare diseases is central for achieving the universal health coverage globally. One sentence that I have really liked, that I have heard from the moderator of the previous table, was the rare diseases solutions are not just rare diseases solutions, so are solutions for the whole healthcare system. When talking about rare diseases, we should be focusing on how to strengthen the healthcare systems that we really have in order to achieve to cover the needs for the people living with rare diseases. So now that we should be thinking about what the Global Action Plan on Rare Diseases is going to incorporate, I want to stress 5 contributions that I think that the Global Action Plan should have. First of all, should be talking about the rare diseases care model. How we are going to face the needs of the people living with rare diseases, where rare diseases are going to be assisted, how we are going to benefit from digital health solutions in order for the people to have the most specialized assistance, the closest to the place where they are living. This is one of the things that we should be addressing. Second one is to provide globally the epidemiological tools and knowledge in order to get a proper surveillance of rare diseases all around the world. We should be working on the diagnosis, but also on the register of the cases to be able to take the care to where people are living. The third point is related to the early and accurate diagnosis. And I want to focus on a couple of topics. One of them is related to the development of molecular diagnosis and genetic diagnosis capacities all around the world. And the other one is related to a very concrete group of population where further disabilities can be prevented. And it's newborn screening. Developing capacities on newborn screening is going to prevent further neurodevelopmental harms and neurodevelopmental disabilities. So this is one of the high value, high return focuses, the dimension where we should be focusing. The fourth one is about promoting R&D. When we are talking about health equity, and many times we do it with an utilitarian perspective, we tell us that the investment should be done where we are going to take the highest revenue. This is not true when talking about rare diseases. Rare diseases should receive investment in R&D, not because of the global amount of revenue that the companies are going to get, but because a matter of justice, a matter of the need to address the situations and the conditions that everybody can develop in a concrete moment on their lives. And the fifth one is related to the access to therapies. I think that we are in a moment that we cannot talk about innovation if innovation is not accessible for the people who need it. So accessibility is a possibility condition for innovation, and this is something that should be put on the table. The Global Action Plan should be talking not just on research and development, but also on how we are going to do for these therapies, and very especially when we are talking about very expensive therapies such as advanced therapies and so on, how we are going to do that they are going to arrive into the patient. So with these 5 main points that in my opinion, it should be included in the Global Action Plan on rare diseases, I want to stress that it's not going to happen without political commitment and political leadership, and we should be encouraging political leaders to commit with the development of the Global Action Plan, but also it's not going to happen without rare disease patients' organizations' engagement and participation in the development of the Global Action Plan. And to give an example of this last thing, I want to tell you that as in Spain, we are developing a patient organization law in order to guarantee the participation and engagement on patients' organization, not just where decisions are informed, but also where decisions are made. And rare diseases patients' organizations are having a concrete position, not because of the high amount of patients that are represented, but because rare diseases have concrete needs and concrete singularities, and they should be in the places where decisions are made. So I hope that if in 1 year from now we are celebrating another event in the sites of the World Health Assembly, it will be to talk about the Global Action Plan already being implemented and not being projected. And thank you very much.
Okay, thank you so much, Dr. Padilla, for those very insightful and very practical remarks about sort of concrete steps for the Global Action Plan and really the importance of patient engagement. So thank you so much. Now I think, we've heard so many wonderful insights about how rare diseases can truly be a catalyst for UHC and for global health strengthening more broadly. And just to close tonight's event, now it's my honor to invite Flaminia Macchia, the Interim Executive Director of Rare Diseases International, to close our event.
So, as you know, Rare Diseases International is a patient-led organization. This means that RDI is led by people with lived experience of rare diseases, either as patients or as family members, and daily caregivers of persons with rare diseases, all united in one goal: a better and longer life for their loved ones. Like all mission-led organizations, RDI does not give up on its objectives. Yes, we heard it today again and again, they're daunting. But the rare disease community is made up of individual warriors who are not easily intimidated, because nothing compares to fighting for those we love. If I get emotional, it doesn't matter, okay? So as highlighted by Radha, it can all start by one person, because the whole humanity is in every person. So, and everyone in this room, in one way or another, is contributing to this fight, the fight for a better world for people with rare diseases and for all those facing the daily multidimensional challenges that come with rare diseases. And the video highlighted some of them: diagnosis, medical care, and as underlined by Claude, also social care, treatment, recognition of rare diseases, and the needs linked with rare diseases. So let me thank everyone who contributing to today's event. So first, the representatives of the member states who are unwaveringly supporting rare diseases and who carry the responsibility of designing health systems that meet the needs of our community. You know that systems which are patient-centered and equitable and inclusive of people with rare diseases are not only the right thing to do, but also systems that are better equipped to better respond to the needs of all your citizens. And as was underlined, all citizens with the same rights. I think it's you, Jérôme, who mentioned that. So indeed, equity drives excellence. In particular, I would like to thank Dr. Javier Padilla Bernaldez, Secretary of State, Ministry of Health of Spain. As you know, Spain and Egypt are, as the two lead sponsors, were key players in the process leading to the WHA resolution, which, let's remember, is titled Rare Diseases, a priority of global equity and inclusion, so it clearly means that equity and inclusion can only be achieved if rare diseases are addressed. Let me thank Jérôme Weinbach, Deputy Director, European and International Affairs of France, a truly pioneering country in rare diseases with its early-time national plans and national networking of expertise, which inspired scaling at European and global level, and also France's strong patient advocacy. Also, thank you for underlining the importance of clear targets and the regional dimension and private-public partnerships and data. Let me extend my gratitude to Adiratna Bindimat Ripen, head of the Cancer Research Center from the Institute of Medical Research of Malaysia, and its strong commitment to persons with rare diseases. You also mentioned the newly adopted policy, the need for action plan, and highlighted synergies with precision medicines and the importance of registries and genomics. Thank you for that. And now I get emotional. Let me now warmly thank the WHO, which was represented today by one of the first and long-standing champions for rare diseases at the WHO. Durhan, you might remember that. Dr. Rudiger Kresch. I'm not going to say his titles, there are too many. So we extend our sincere gratitude to the WHO as a whole for ensuring that rare diseases remain high on their agenda, even in this particularly challenging global context. And I really loved, and I told him I was sad he was leaving, but before hearing this, but he said, rare diseases help to get compass right in global health. And we here truly believe this. And he also added, rare diseases are in the center where you have to be. So, as we heard today, rare diseases remain a priority for the WHO, who is busy preparing for the development of the Global Action Plan. We heard it yesterday, we met with them, and the consultation process. So please rest assured, rare diseases are firmly positioned within WHO broader goals of universal health coverage, equity, and inclusion, because we cannot claim to leave no one behind, unless and until the needs of the rare disease communities are addressed and the communities fully included within sustainable development for all. And indeed, as you underlined, Kirsten, rare diseases intersect with many global health priorities. We'd like to thank you, Claude Meyer, another title that is very, very long. But you are at the WHO and you are adding this crucial element of health economics perspective to the event. You also said that, which is very important, financing and delivery mechanisms should be in sync. I would also like to warmly thank the co-sponsors of this event. KP Tsang, co-founder of the Hong Kong Rare Disease Collaboration Network and former RDI Council member. Thank you, KP. You mentioned that rare diseases should be looked at the source of the solutions for healthcare systems, and how the rare disease field launched the referral pathways, the multidisciplinary care that can be used for chronic diseases. And you also mentioned the importance of patient engagement shaping policies. Anne-Sophie Chalandon, do we need to introduce you? Not really. But today you are representing the IFPMA Industry Collaboration Group on Rare Diseases. I still vividly remember when this group was launched and created back in 2022. You were there, you're still here. Thank you. And we welcome what the ICG on rare diseases has achieved. till today. Thank you. So I will take this opportunity to also thank all RDI's corporate partners for their steady support over the years and for being here today. We are also very grateful to Ghada Mounib, founder and head of Board of Trustee of WHA Foundation for Rare Diseases, a charitable foundation in Egypt dedicated to treating children with rare and life-threatening diseases. Thank you so much for being here today and for your support. Let me also warmly thank the other foundations and non-profit organizations who generously support our mission. Very importantly, and looking at the future, we thank Tony Roberts for representing the RDI Youth Leadership Program and for ensuring that our mission is being so wonderfully carried forward by the next very mature generations. Please let me also thank our current and former council members who steadily ensure that what drives RDI is only the interests of the global rare disease community, and that this focus translates every day into RDI's strategy as informed by the lived experience of people living with rare diseases. So I'm going to mention them. Tony, who sadly cannot be here today, Diego and Ritu, Kirsten, Monica, Nadia, Kelly, you are here. So RDI, like any other membership organization, would be nothing without its members. So we are grateful to our 144, Alana, right? Members in 6 continents for trusting RDI and for joining forces for rare diseases globally beyond their national and disease-specific focus. Only together we can advance rare diseases for all. We also thank you all for attending this event today and for showing up to demonstrate your support to rare diseases and RDI. It means the world to us. And finally, a huge thank you and deep appreciation to the RDI staff for their professionalism, resilience, and dedication and passion. I will mention specifically Alana Miller for her policy work and for the side events today. Sandy Laham for managing our partnerships and resources. If you do that, we are here. Sarah Brambilla for managing global programs together with Monica Drum and Robin Duran. They're not here, but Sarah is here. Alba Parejo for managing RDI strategic engagement together with Deborah Bellon, and Tihani Carrillo, who recently joined and already contributed. Marco Pasetti for ensuring finance and human resources. Be careful. And Alexandra Lianes, who orchestrates everything that you don't see. Thank you for them. And I finish by saying that we firmly believe that by working in the spirit of SDG 17, partnerships for the goal, as underlined repeatedly by KP and by Anne-Sophie's 6 PPPs, RDI will continue to advance its mission while ensuring that the interests of persons living with rare diseases and their families remain our constant guiding star. Thank you for your presence and attention.
We'll let everyone go. Thank you so much for coming. I can't say more than Flaminia has, so thank you, everyone. There will be a reception just up the stairs or up the elevator, and we hope to continue some of these conversations. So thank you so much.